This is IAQ Radio, Indoor Air Quality Radio, the voice of the indoor air quality industry, with your hosts, Radio Joe Hughes and the Z-Man, Cliff Zlotnick. And now, Radio Joe Hughes.
Good day and welcome to IAQ Radio Plus. It's episode 761. We're back from our summer break, and this week we've got a great show. We welcome back Dr. Irene Grant. We're going to talk about her experience treating people for mold infections and other fungal-related medical issues. She last joined us in 2013 and has been actively treating people ever since. We're going to learn more today on IAQ Radio Plus. Before we get started, let's thank our sponsors. They're the reason we can continue doing the show. IAQ Radio's marquee sponsor is the Institute for Inspection, Cleaning, and Restoration Certification, IICRC, a nonprofit standards development and certifying body for the cleaning and restoration industry at iicrc.org. IAQ Radio Association sponsors are the Restoration Industry Association, RIA, at restorationindustry.org. The Environmental Information Association, EIA, at eia-usa.org. IAQ Radio industry sponsors are Particles Plus at particlesplus.com, Tramex Meters at tramexmeters.com, EMSL Analytical Inc. at emsl.com.
And now you can win a cool prize. It's time for the IAQ Radio Trivia question. Be the first to correctly answer. Simply email your answer to czlotnick at cs.com. Or if listening live, just text your answer from your computer. And now, here's the Z-Man.
Hello, everyone. I'm sorry to report that no one correctly identified John McCarthy as the American computer scientist who in 1955 coined the term artificial intelligence. Here's today's IAQ Radio trivia question. What is the difference between a mycotoxin and an endotoxin? Back to you, Joe.
Okay, Dr. Irene Grant is an infectious disease specialist with expertise in infectious complications in the immunocompromised. In the 80s, in the midst of the HIV/AIDS epidemic, she trained at Memorial Sloan-Kettering Cancer Center in New York City, where she acquired training in microbiology and hospital infection control. Thereafter, she spent years in academic medicine as an assistant professor of medicine at the Albert Einstein College of Medicine and later clinical assistant professor of medicine at the New York Medical College. Later in private practice, she applied her experience investigating unusual illnesses to help her patients sick from hazardous indoor exposures. For the past 24 years, she has evaluated and treated hundreds of debilitated patients and families with hazardous microbial exposures. Welcome back, Dr. Grant. Always great to see you. Hello, Dr. Grant.
Hello.
There you are.
Thank you.
Welcome back. It's great to see you again.
It's good to be here.
All right, let's get a little start with catching up on what you've been up to the last 12 years or so. I'm assuming from your bio you've been kind of in private practice lately, but please tell our audience.
Well, in the last 12 years, my focus has really become exposures to indoor hazardous molds and mycotoxins, and I've seen, since we spoke, numerous clusters of families, pets together exposed to the same buildings. And my focus has been always to try to get the whole spectrum of the situation, from the indoor science and the testing by industrial hygienists or inspectors, as well as the patients, getting a thorough workup and evaluation and following the outcomes longitudinally. And I have been trying to present, every single year I've gone to meetings, mostly in Europe, presenting outcomes, focusing on disease severity outcomes.
Are you still in New York City?
No, I'm not the city. I'm in Westchester. I'm outside New York.
A little north of, is that north of New York?
It's not.
Okay. All right. Let's start a little bit with some of the cases you've dealt with of fungal infections, because I think that's an area of, I don't know, we don't get to talk about it a whole lot. What type of fungal infections do you commonly see, and in what types of people?
You mean in the indoor group? Uh, Fungal infections are, I mean, there are environmental fungal infections, which most infectious disease doctors focus on, such as coccidioides and histoplasmosis. My focus has been the hazardous indoor space and the fungi that are involved with that, which are mostly Aspergillus penicillium, Chitomium, and Eucor are the top of the list for.
What about, I noticed you've dealt a lot with Stachybotrys.
Well, you asked me the question of infection. Stachybotrys, as far as we know, except for in very rare cases, is not thought to be infectious, except for possibly in the very immunocompromised. But there's only a scattered bunch of cases where they found stachy growing, but it's not quite an infectious mold. But it's a very, very toxic and damaging mold to be exposed to.
So it doesn't grow in the body like others, like Mucor or Aspergillus, etc.
Well, actually, that's the hot topic.
Ah,
Infection is defined usually when it comes to mold, when the molds start to grow and penetrate into tissue. So colonization is not really considered an infection.
so
In the mold world. I mean, when you talk in the bacterial world, we can go on and on about Clostridium difficile, which will make a nice toxin, and it's considered a toxin producing. But that biofilm is an infection because you would treat it with antibiotics. But that paradigm has not yet been accepted in the infectious disease community, which is
why do you
one of
think,
my, yeah.
why isn't it accepted yet?
I think it's a combination of many factors, and I've been trying to figure this one out for decades. Why? Because I trained in a cancer hospital, Memorial Sloan-Kettering, where we had top of the line microbiology. You could get any stain, you could get any culture, and they had on staff of mycologists. So I was living in paradise in my training in terms of fungal diagnostics. The problem is diagnosing fungal infections in the outside Sloan-Kettering is that the laboratories do not have the proper media and so forth. For example, if you were really going to diagnose an unusual mold, say you have to keep the specimen for 6 to 8 weeks. LabCorp requests don't do that. And then you have to have a mycologist go look at the slants, look at the microscope, go into it's very complicated microbiology. It's mycobiology. And mycologists are rare. And now with fast diagnostics, I mean, I'm horrified. The best way to find fungi has always been to see it under the microscope. And it used to be that when a surgeon did a specimen, they would send the specimen to the lab, and the first thing that happens is they would look under the microscope at the potassium hydroxide, the KOH test, microscopy. You can't get that anymore. And I was laughing to myself during COVID when India said they had a problem with Mucor after COVID, and they had a big Mucor is one of the black indoor molds. And then there was a big article by somebody or a letter to one of the journals saying that's not a problem in America. And I'm going, well, yeah, you can't diagnose mucor in America. So of course it's not a problem. Nobody's doing a KOH on sputum anywhere. And so only in academic hospitals that have on-site microbiology labs and mycologists are you finding unusual mold. And then the public thinks that hospitals are toxic places because that's where the molds grow. No, the hospital is the only place you can diagnose them. And so we are very behind in having the capacity to work up molds in the human body. In a way, the house is doing.
Uh-oh. We seem to have lost Dr. Grant. There you are.
Yeah.
We lost. You're back.
Oh, the only doctors that are, there's two groups of doctors that are, I think, up to speed with understanding this problem are the pulmonologists and the oncologists, and because they have access to get the workup. But most doctors across America don't realize that they cannot get fungal mold culture. You can get a candida culture, which only takes 5 days.
That's very interesting. Is it only people who are immune compromised that can develop an infection, a mold infection, a fungal infection?
No, some people do. It depends on the pathogenicity of the mold. Aspergillus fumigatus is a very pathogenic mold that will infect anybody if you really get a good dose of it.
And how
you can
often
get a fungal pneumonia and so forth.
I assume you work with people who go out and investigate homes, and that's part of. I don't know if is that part of your practice. Do you refer people to inspectors?
Yes.
Okay, and I'm wondering how often do you find like Aspergillus fumigatus that needs a higher temperature than many molds, as I understand it, to grow in indoor environments. How often do you actually find that in indoor environments?
Oh, in fact, if I don't find it, I suspect the testing wasn't very good.
Okay, interesting.
Again, it's not Aspergillus fumigatus is all over the place, but it's the dose.
Okay, and what type of patient is most vulnerable to these types of infections?
Patients with immune defense damage, and I include what I call the barrier. And the mucosa of the body has a barrier function in the nose, in the throat, in the GI tract. There's that whole area. It's got the mucin production, and the whole thing is like a conveyor belt that gets rid of stuff. The immune system is in there with the macrophages and so forth. So someone with a strong immune system will clear those areas. So that's the barrier. If that gets injured, that's where Stachybotrys comes in and macrocyclic trichocythine. If that gets injured, like a burn, and a real burn, then these molds will take, and that reminds me also, I forgot the skin. The skin is the number one barrier. But if that gets injured, mold is a real serious infection because mold has a chance to get in.
I remember 12 years ago, you were talking about treatment and some of the drugs that we have for treating these types of infections, and that they were more available, at least in certain forms, in Europe than they are in the United States. Can you talk a little more about that and whether that has changed?
go there, I want to just finish clarifying what I think is a misunderstanding many, is the difference between colonization and the capacity to infect. So there's the barrier, the white blood cells that fight against mold. And the number one is macrophages and monocytes.
Okay.
And the HIV-associated cell-mediated immunity, T cells, used to be called T cells, or now CD cells before. And these are key for stopping mold penetrating. And if you've got a problem in that area, that's where the different medical conditions weaken those immune functions, such as steroids. Steroids really stop. Steroids do two things. First, they hamper the immune system. And if there's evidence that molds really like steroids, and they start to grow better. And the other one that's of great concern is these drugs that are being used now a lot by rheumatologists that also knock down the immune system. And then you see fine print in that drug saying, careful with fungal infections. And of course, chemotherapy. Those are medication-related immune problems. And then back to the barrier problem. If you've got scarring and lung disease, such as COPD, any kind of lung stuff, that's actually a high risk for fungal infection, especially aspergillus. So chronic lung, diabetes, cancer, and of course, AIDS.
Now, we also talked about, I don't know, I guess it's colonization would be the better word, of the sinus tract, and that you were able to get medicines to help with that, but that they weren't easily available in the United States. Can you talk to our listeners a little bit about that?
Again, everything's in stepwise. If you catch something in the colonization phase, and you can dissolve and get rid of fungal colonization, then you don't end up with having it crawl into the crawl spaces of the sinuses. So that it's, to me, the number one area that people from indoor exposure get sick. Number one is the nose and the sinuses. And the most frequent finding is actually sore throats, inflamed throats, because and what struck me from the antifungal point of view, wait, I got to back up. What's unique about the molds is that they've got two styles of survival. One, they went the spore. This is a very almost cartoon explanation. The spore will land, and then it'll start to spread and make hyphae roots, just like a little plant. And then around those hyphae, it makes all sorts of biofilm ingredients that protect it. It sets up this mass. And then from that mass, it'll sprout out and make more spores. I sort of like the dandelion model. And that's a biofilm by a mold is completely different than a biofilm by a bacterium. Completely different. And these hyphae almost look like steel wool, and very few medications will dissolve these hyphae, let alone get into the biofilm, because the biofilms are usually water compliant. And that's where amphotericin, which scares doctors, but when you give it intravenously, it's really dramatic drug. But given topically, as a molecule, it's too big to cross over into the tissues. If you drank a bottle of amphotericin, it would just go through you. It would not get into your blood. It would not go to your liver. But the amphotericin will dissolve high fever. And it was Joseph Plonicow, who was an ear, nose, throat doctor at Cleveland Clinic around 2000, who did this very good work showing that his using amphotericin helped his ear, nose, throat patients that did have fungal sinusitis. And I basically have been using his protocol, and it's very effective. I believe it belongs on the mouthwash toothpaste zone. It's when you think of it, what we do with toothpaste and mouthwash is very toxic, and the dentists have gotten us convinced that this is what we should do, and it does work. And amphotericin, cleaning the nose and cleaning the throat and the mouth periodically, to me is just hygiene. With people who have really been exposed, it's much more important than just hygiene. It's stopping progression to a deeper infection.
And I also noticed in going through Cliff's blog from your last show that a saline sinus rinse does help some. Can you talk a little bit about that?
Saline is I'm fascinated by saline. I think saline is the overlooked antifungal in medicine that's been around for over 100 years. When they do surgery, they just flood the body with saline and clean out everything because it is antifungal. And it would be the perfect thing, except for the problem is if you swallow saline, it's salt, sodium chloride, you're going to give people high blood pressure. It's not good. I think using saline and blowing your nose and not swallowing it is a very good idea. There's some over-the-counter things, sodium bicarbonate, so forth. I think they're excellent, but you don't. But here's the problem with I've noticed in people that the trouble area is right in back behind the nose, above the mouth, what's called the soft palate. And that's where people can end up having this thing they call postnasal drip. You can hear them crashing and bringing out, and they can't get this cleared. That is, to me, one of the crawl spaces. And using amphotericin. And from that, this is my hypothesis. Some scientists will help really further research on this. From that, I think that is causing a lot of toxic exposure. If you have a biofilm there, molds they're basically factories. They don't just make mycotoxins. It's known that one colony of aspergillus can produce more than 20 different toxins and gases and VOCs at the same time. And so anybody with that kind of colonization up here, it's logical to me that they would have sore throats and all the way down to gastritis and so forth. I know that the GI people are saying that reflux causes sinusitis. I'm saying, well, in the indoor population, I think it's the other way around. I think the sinusitis is causing the gastritis and the leaky gut, and because I'm saying that based on work I did with my medical student James Rini years ago, where we looked at all the symptoms and just cleaning the sinuses cleared the GI symptoms, cleared the chronic fatigue, cleared the arthritis, cleared the pain, cleared it. And I was saying to myself, that makes no sense. How could that be? Amphotericin is not to work. How can that cause systemic, radical systemic improvement? And I went, yeah, we got rid of the factory, got rid of the toxin factory that was up in the sinus area.
I wonder some people who I've had on the show feel like there's kind of these silos. There's the industrial hygiene area, there's the remediation people, there's the medical community, there's the engineering community, and it's sometimes tough to get information between those communities. I wonder if you've noticed the same thing, and if you have any suggestions for how we can better get these different communities to work together.
Oh, I have absolutely noticed this, and I've just gotten to, I work with my own little team of industrial hygienists. I work with her and Sabbath, and I work with Gina Deemer, Matt Duggan, and others. And I go for ones that I know and I trust. But I think the first rate limiting problem is the ball's in my court. That I haven't yet convinced the medical world that this is a real diagnosis. And I think the problem is that when someone is exposed indoors, it's so complicated because it's two things. One, it's toxicology. If someone has got a toxic hit, and that causes all sorts of problems, and it's simultaneously an infection. So people complain about everything, my skin, my hair, my this, my nose, and the doctor goes, please go see a psychiatrist, because we're all taught to see patterns, but a real sick indoor person has too many patterns going on simultaneously. And we don't yet have good biomarkers. We're getting there. There are some. And I'm finding that the two mycotoxins that are useful are gliotoxin and the macrocyclic trichosidine.
Now, when you say useful, is that because they're, I'm trying to think of the right wording here. It's the gliotoxin, as I understand, may be produced by the molds as they colonize the sinuses. Is that accurate, or is it in the environment, or both?
Well, actually, I was very interested in that question a number of years ago. I looked at this because I had in my my cohort, I had people who had gliotoxin in their urine and gliotoxin from the indoor space testing. And I found no correlation, but let me back up and say that gliotoxin is produced pretty uniquely by Aspergillus fumigatus. And in work with oncology, oncologists have found that gliotoxin inside a patient is a marker for the hyphae, the roots, trying to drill into tissue. So it is a marker for an infection when you find it inside the human body. So that's why I went, well, that's interesting. What happens when you breathe it, eat it, so forth, your house is full of gliotoxin. And I looked at we did biostatistics studying that, and I found only gliotoxin in the house only correlated with you've got aspergillus in your house. And it was not correlated with any disease, severity, or illness. Whereas gliotoxin in the urine, those were my sick patients that needed therapy. Which I like because it makes sense. And that's why I find gliotoxin now a very useful mycotoxin. All these other mycotoxins, ochratoxin, you can't say if that came from coffee or whatever. Right now we don't have the science on that. But gliotoxin is useful because we have that science. And the macrocyclic trichosidines are useful because they mostly come from stachybotrys. You're not going to find those in the food chain unless, of course, we're getting into floods and having to store them stachybotrys. I hope not. But at the moment, macrocyclic trichosidines in someone's urine tells me, whoa, you got to look where are you getting that, because it does have a half-life. You're not going to be excreting macrocyclic trichocephene for the rest of your life. They're showing now that means not you have been exposed. I can't exactly say when. I'm really yearning that some good epidemiology will take place. Actually, that answers your original question. This fragmentation of specialties. I remember when HIV was first discovered. At first, it wasn't accepted as theory at all, but then in the next several years, there became a real coming together of many different disciplines, and that people brought their expertise from immunology to pulmonology to just so much from public health. And mold needs this exact same thing. We really need to come together. And I mean, I now look, I thought HIV was a horrible epidemic, and now I'm sitting there going, wow, I'm not even sure it was an epidemic. Compared to mold, it was in fact big.
Wow.
Mold is global.
Listen, let's go to halftime. Thank our sponsors. We'll be back to the second half of our interview with Dr. Irene Grant in about 1 minute. IAQ Radio's marquee sponsor is the Institute for Inspection, Cleaning, and Restoration Certification, IICRC, a nonprofit standards development and certifying body for the cleaning and restoration industry at iicrc.org. Our association sponsors are the Environmental Information Association. EIA's multidisciplinary membership collects, generates, and disseminates information concerning environmental and occupational health hazards in the built environment at eia-usa.org. The IICRC, a nonprofit standards development and certifying body for the cleaning and restoration industry, iicrc.org. The Restoration Industry Association, the oldest and largest nonprofit professional trade association dedicated to providing leadership and promoting best practices through advocacy, standards, and professional qualifications for the restoration industry at restorationindustry.org. Industry sponsors are Particles Plus, feature-rich particle counters and air quality instrumentation. Count on us, particlesplus.com. Tramex Meters, innovation in moisture detection and humidity monitoring systems since 1974 at tramexmeters.com. EMSL Analytical Inc., providing high-quality, full-service laboratory services since 1981. EMSL.com. All right, we're back with the second half of our interview. We've got Dr. Irene Grant. Cliff, I want to make sure, did you have any follow-ups or questions you wanted to add?
No, I didn't.
Okay, Dr. Grant, I want to go to another topic that's been kind of current in the industrial hygiene world. We talked earlier in the week, we talked a little bit about the ACGIH bioaerosols book and the AIHA's mold and dampness white paper. And there's been a lot more discussion of beta glucans. And I'm wondering what your thoughts are on that as a kind of an appreciated component of the fungi that may be causing some of these problems.
Beta glucans, which are from the cell wall of molds, are definitely inflammatory. I think no one will argue with the fact that the real unequivocal problem with the indoor space is dust. Trying to point out, I've focused in on stachybotrys and so forth, because I'm hoping to define something. But dust contains many, many things, including many toxins. But BDG is absolutely immunostimulating. But the other thing that's so ironic to me in the environmental medicine community and in the holistic community, they're using beta-glucan, supposedly to help rev up the immune system to be able to fight infection. So this is some really good science needs to be done here, because there's evidence that BDG, it can be somehow a good thing, helping rev up, or is it a confounder? And there's so much science really needs to be done. And I think the one reason the scientists will get it done is because it's such a messy area. The indoor space is daunting in its complexity. Nevertheless, the work must be done.
When we were talking, you mentioned a really bad, what is a really bad house? So I wonder if you could tell our audience what you consider to be a really bad house for someone.
That's what I've taken my database. Actually, I've developed this database because I was involved with a database for the HIV surveillance when I finished my fellowship at Sloan-Kettering, South Bronx, and I created this whole database that the Department of Health and CDC used to help track HIV, and in some ways it's so similar, because in HIV there's asymptomatic, and then there's you're getting sick, and then there's AIDS. Well, mold's the same. Some people don't get very sick, then there are other people that are like, and then you've got the really sick. So I have been building my experience in the exact same way, and charting my patients. So what I'm going to be telling you is based on my work with people. What have I found? Because that is a question. And I have found that there are certain events that are very, very, that are red flags. And first of all, you need a contaminated building. Construction, that's not a red flag. But if you've got in the contaminated buildings that are of the most concern for me are the ones that have had sewage problems. And I mean, of course, that's not just Stacky. That is, black water. That is, and I know you already know that. Everybody knows that. But clinically, in my patient population, the mathematics agree with that. And that often coincides with Stachybotrys being there, and trichosis. And so that is one really red flag. And of course, unfinished black mold, the extent of it, everything that is already recognized in indoor inspection matches exactly what I'm finding in the patient population. And perhaps the most useful clue is what do the place smells, odors. So those are the first pass clues. But the things that are dangerous is when dust is produced and not contained. And it's the same as in a hospital. If you're going to do construction in the hospital, you've got to seal off that room, and you've got to have negative pressure, and you can't have it, otherwise it spreads in the hospital. The same thing with the house. I would say this is home infection control. And I've seen, and the other thing I've seen over and over again, the sickest people are the ones that go up to the mold and they start to clean it themselves. And they didn't put a mask on, it didn't put goggles on, and they didn't, and it's a direct proximity and intensity exposure, unprotected, intense exposure.
I've got a text question here. It's kind of lengthy, but it really goes to the heart of what we're talking about. It says the science establishes that fungal infections are associated with agriculture, industrial, and hospital-acquired exposures. Severely immune-compromised patients are also susceptible to fungal infections, and opportunistic fungi are present in indoor and outdoor air under background conditions. what studies have demonstrated causation of fungal infection in occupants exposed to indoor mold growth or fungal infections in mold remediation workers, which is an area of my particular concern? Has there been any epidemiology investigating this?
Thank you. That's a wonderful question. And that's actually the carrot that keeps me going. I'm constantly I do have cases where I have one case where this woman, it's very hard to do a causation case, and especially when you don't have access to Memorial Sloan-Kettering Microbiology lab. This work has to be done. In my own experience, I've had numerous cases clinically where I treated them, and actually, I have one case which is very, very convincing, where the woman was exposed to very high levels of indoor bipolaris, which is unusual, and also had sewage. And
Also had
she
what?
ended up bipolaris. She was exposed to a sewage contaminated apartment.
Okay.
And we cultured bipolaris out of her out of her sinuses at surgery, and she required intravenous amazone for treatment. So that was a case of causation, sure.
So
And
is that kind of what you're trying to do with your database?
yes, absolutely, yes.
And
The problem, actually, that is the problem all across infectious disease. You're always going, is this definitive or is this probable? And you could not prescribe antibiotics if you don't go through that process. And how many times you go, well, it's not definitive, but it's probable. I'm going to give, this antibiotic combination.
do you run into?
Anyway, so that is the burning question.
Have you?
And that work needs to be done. That work needs to be done. And if I could live long enough to find a way, I would want to take these people that I do find with the industrial hygienists and get their sputums in their individual. I mean, right now, if you coughed up a black sputum or a nasal tube was black, I would have no way to get it evaluated. There's no laboratory out there accessible to me where, unless I send it to Germany to say, oh, did you find Stachybotrys in here?
I think it's safe to say if you can't find a place for that type of analysis, then none of the medical community is able to find that, or is it different in other parts of the world?
I think, well, they're waking up to this. Oh, actually, that's my bad. And there is absolutely a causation case out of England. I think it was 2 years ago. A little boy was complaining at home, and he died. And they found the same mold in the house in his body. That was an absolute case of causation.
Yeah, that was in the news quite a bit. Now, the other question I'm getting is, can you cite any studies establishing that indoor Stachybotrys has caused toxicity symptoms? Is this all your anecdotal information from?
Oh, I've got so many abstracts on that one. I've been submitting my abstracts and going to meetings since 2011 on Stachybotrys and symptoms. I'm in the process of trying to publish. And I've presented at the the Society for Mycotoxicology. I presented last June in Vienna on the neurological symptoms of Stachybotrys. And I'm going next week to Spain to present on. I've got two young girls had atypical episodic ataxia, and they weren't getting better with standard therapy, and they were exposed to Stachybotrys for sure. And so it's an indirect, but but actually that's usually the situation. I find Stachybotrys and a secondary opportunistic, if you will, fungal infection, and then treating with antifungals causes a good outcome. But again, that's not definitive enough. Yet we really need to get good infectious disease work achieved.
You know,
And it requires funding, it requires specialty laboratory work, it requires having the right, a real consistent way of testing. My dream would be to work with the team of inspectors that I really, really know are going to do a thorough job and send the stuff to the right indoor mycotoxicology lab, and also take the medical specimens to the right mycology lab and pathology lab. That work, I don't know if that will happen in America, but I think that work needs to be done. I know they're getting much more serious about this in England.
now, part of that question was about remediation workers. I'm wondering, have you in your practice ever had remediation workers come to you?
Yes, yes, yes. And actually, that the remediation workers worry me, because some may be these wonderful cowboy personalities, and they think that they're invincible and they're not allergic. And I'm like, if you're up against Stachybotrys, you're in danger. I don't care how healthy you've been. Lucy would have a problem.
Why don't we go to our roundup, Grayson? All right, the roundup brought to us by Tramex Meters at tramexmeters.com. Cliff, I want to check, see if you had any comments or questions.
Yes, Joe, thanks. Irene, what about your patients after they've been, cured and corrected and so on and so forth? Can they move back and occupy their homes? There have been, situations, I think, historically over years where some people supposedly were so sensitized they couldn't move back into their homes and so on and so forth. What has been your experience?
It depends on how thorough. Well, it depends on the home. I mean, to me, this area of mycotoxicology is important. You can disinfect, and then I've seen this over and over again, actually, where they find Stachy, they get somebody to clean it up, the Stachy's gone, there's no more air. But this was Jack Brasher's mission, and I hope to replicate that, was to say that since macrocyclic trichocenes are electrically charged, you look for them in the back of the refrigerator, or you look at the inside the HVAC to see if they've been disseminated into the dust. I mean, of course, they're not airborne; they're airborne in dust. But that's a study I hope somebody does. That would be a quick and dirty way to say, this is a bad place. This place is bad. And the problem with the trichocenes is that they're tiny, they're smaller than COVID, and you can clean a place, but you've got to clean them of trichocenes, and the usual ways of just using Clorox and so forth, that doesn't apply. So this is a whole area I would really like to really help with. And when it is my favorite, this is my favorite. So I'm chemically sensitive, so you pull out Windex or Pintacid or anything, I'm gone. dealing with the mycotoxins since they're electrically charged, you want a distant or a cleaner that's both gets the negatively and the positively charged. My favorite is vodka. The Everclear super concentrated, because isopropyl alcohol is toxic to humans, but you can clean with that and really get rid of dust that way. And I've had people manage to get their houses back, but you've got to be really, really, really thorough. And the usual standards right now just doesn't include the mycotoxins, which is okay if you don't have Stachybotrys. But if you've got Stachybotrys and macrocyclic trichocephalides, you've got another problem. That's another challenge. I just have my homemade ideas.
I've got a text question that says, number one, thank you. I appreciate your perspective on infection and treatment. Could you put the specific sinus treatment you noted into the chat, or maybe we could also get it from you and then Cliff could put it in his blog, which might be a little easier for you.
It's compounded. Various compounding pharmacies take amphotericin B powder and put it into sterile water, not saline. Saline deactivates amphotericin. You need it to be water, and they say, "Oh, it's not soluble," and that's it. I'm like, it still works. I don't care if it's not soluble. It still works, and the dose is 300 milligrams in 500 cc's of sterile water, and the person keeps it in the refrigerator and sprays it in each nostril a lot, like 20 sprays each nostril every 2 to 4 hours when you begin. That's what will help dissolve it. And I call it just showering inside the nose and swallowing it. And that often causes great benefits in less than a week.
Okay. The rest of that question is stachy growing in usual indoor environments certainly indicates that the environment supports conditions for a whole biological soup. And that, I think that's well said. And seeing it in urine states exposure, is there any evidence there is enough of a dose by inhalation to cause true toxicity?
Inhalation is the most dangerous and the most effective. With the macrocyclic trichocephine, the dose required is Harriet Almond thinks it's only 1 or 2 inhales. If there's evidence in animal research that if the trichocephines access the olfactory nerve endings in the nose and go straight up into the brain and down to the amygdala right away. So inhaling is absolutely, unequivocally the most dangerous. Just at the nose, if it does reach the lungs, the trichocephines are tiny. They just go right into the blood. So a macrocyclic trichocephine contaminated environment is unequivocally dangerous, especially for inhalation, especially.
Let's talk a little bit about your plans for the future here. I know you're doing I guess a seminar online here, and we put the link in the show announcement today. We could probably also put the link to your website in the chat and in the blog. But I wonder if you could tell our audience what, you've been going over to Europe, you've been going to a lot of these different conferences. You're still, I assume you're still practicing. But correct me if I'm wrong. What are your plans for the future?
Well, my dream is to somehow replicate what I witnessed was done for the AIDS epidemic, because what I see in there's many similarities, but the number one difference is all these poor people are really at their wits' end, and many of them are broke, and how to deliver top medical care and help them. and at the same time collect high quality epidemiology data. Did with HIV, so that I was involved. And that's how I got my training. I was all the patients. I was trained. The patient got affordable treatment, and then all the research was collected, and that's how all the work was done for developing the antiretrovirals and everything. And that needs to be done for mold, and I don't know anybody else doing that. So I was going, well, I've done that. So as I live in my twilight years, that's something I'm called to do, is to recreate a system where the people come, they get top treatment, more doctors learn how to deal with this. For me, it's a training. You're not going to learn how to handle these patients in, a weekend course. And then to take that data and really give out some good, high quality epidemiological science.
Can you tell us a little bit about the data? We talked a little earlier about the database that you're putting together now. I guess, can you give us some early insight on what you're finding?
Well, the number one thing that I find, I've just been doing what I did for AIDS patients. I collect everything, the symptoms and the outcomes, and so it's been ongoing since I started seeing these patients more than 25 years ago. And I'm finding, that's why I'm doing these workshops, that if people would just understand the dangers, and just like AIDS and safe sex, this is mold and safe, clean, safe living. If people would just learn, that's why I've decided I can't go through the medical community and try to get guidelines out there for medicine. No, this has to reach public health. This has to reach the do-it-yourselfer. This has to reach the housewife.
Gotcha. Now, are you going to keep doing these kind of seminars? Is that something you plan on doing more of in the future?
That's my current plan. I'm open to advice. To me, I feel like the story about the little boy with the finger in the dike. And I'm like, hey, help. This is my current solution to what I should be doing. Maybe someone else has better advice for me, but this is my current try.
I got you. You're still treating patients, right?
Yes, I'm holding on to all my old patients. I'm already feeling maxed out. The problem is that there are many, many good, well-intentioned doctors out there, but the problem is the ones that get really seriously ill and need intravenous and heavy-duty antifungals. The medical community doesn't recognize that yet. So the people that get really sick, they're really in trouble.
Interesting. Before we go, Cliff, do you have any final questions or thoughts?
I don't, Joe. Thanks.
Dr. Grant, we always like to leave our guest with the last word. Anything we missed that you'd like to add, or anything at all that you'd like to add?
I'm just so happy to be here and to share this problem. I feel like an Indian scout saying, "Oh, there's smoke over there. Please come."
Well, we appreciate you joining us again. Please consider adding any references to Dr. Grant's publications on mold in the blog. So any of your publications that you'd like to send along to Cliff and we will put in the blog. And that way people can check it out there. All right. This is Radio Joe saying thanks to this week's guest, Dr. Irene Grant. Thank you. It's been too long. Great to have you back. I also want to thank our sponsors, our growing list of sponsors, our loyal audience, and of course, the Z-Man, Cliff Zlotnick, and my co-host, and of course, at the controls, Grayson, Gone Fisher, Gone Fish, Gone Fishing Fisher. And we'll be back next. Oh, by the way, next Friday we've got Dr. Joe and Danny Go. It should be an interesting. They've been running into problems with mold in exterior walls, and how do we evaluate that? We're going to talk about that next week on the next episode of IAQ Radio Plus.
For IAQ Radio, I'm Spike Reel saying thanks for listening.